Hi, good evening. My name is Amer Raza. I'm a consultant gynecologist in Cromwell Hospital. I'm head of International Center for Endometriosis, which is a very busy unit, and I work with a very large and skillful multidisciplinary team in treating complex endometriosis. Thank you for joining us today to discuss a topic that affects millions, but is too often shrouded in mystery and misunderstanding: endometriosis and its impact on fertility. And I know that many of you who have joined us today may be living with endometriosis, are facing the challenges it brings, especially when it comes to family. And you may have your friends, loved ones, and wanting to find some answers. And I thought it's a good opportunity for us to sit with my very good colleague, Dr. Kate McLaren, to discuss this complexity of endometriosis and fertility. Our goal today in this session will be to provide insights and compassionate guidance to help you better understand the way endometriosis can impact on fertility. And more importantly, what are the options and strategies available to support you on this journey? So I will be joined with Dr. Kate McLaren, and I'll be asking her to introduce herself and tell us about yourself. Where do you work? What do you do? And we'll take it from there. Kate.
Great, thanks, Amir. Good evening, everyone. So my name's Kate McLaren. I'm a consultant gynecologist and subspecialist in reproductive medicine at the Chelsea and Westminster Hospital, and I'm also the service director for the fertility services there. And so do a lot of busy, complex fertility procedures in the unit. And I'm just really privileged that I've worked with Amer Raza for many, many years now. And so we together have treated a lot of patients with complex endometriosis. So just really looking forward tonight to talking all about this subject that we're both really passionate about, and hopefully helping you sort of navigate your journeys a bit more and answering some of your questions. So thanks very much for having me tonight.
Thank you very much, Kate. And Kate, you're absolutely right, because we work together in Chelsea Westminster Hospital, and with a very complex and very busy endometriosis center, you are absolutely at the helm of all the fertility difficult questions in our multidisciplinary meeting. So absolutely looking forward to have a lot of questions and sharing the difficult things with you. And we will be also joined later on by Carla Cressy. Carla is a wonderful colleague, and she is the chairman of a endometriosis foundation. She has herself suffered with endometriosis and now joining her own experience to help so many others. She'll be joining us. Has she joined us yet? No? I think she'll be coming online in a few minutes with us as well. So having said that, I think we'll go to presentation now. So the way we're going to format this one, I will talk to you about endometriosis, and then Kate will take you some of the questions and some of the presentation of fertility as well. And then we'll move on to Carla Cressy, and then moving back to your questions. The aim of going to be not to give a long lecture or something, briefly introduce you with the complexity of the topic, and then following on with your questions. We will have very open discussion that how we should address this difficult question. If I have a mild endometriosis, a severe endometriosis, or it's a peritoneal or ovarian endometriosis, and what kind of different options we have at different stages of our life, are different complexities of endometriosis. So we will be taking through all these questions. If you have any question, keep dropping them, because the main idea is going to be that we spend good time in answering your question, which I'm sure will be more fruitful. So I will just start talking about endometriosis. Can I have my presentation, please? So the first thing is, what is endometriosis? Just a few words about it as well. Can you go to presentation mode? Presentation mode. So endometriosis, we all know now that how common is the problem. As we get to know more and more about it, we're finding out that actually the number 10% we used to say of women of reproductive age suffer with it. 250 million women in the world. I think this number is going to go up as our education and understanding of endometriosis gets better. But it's a big challenge. There is no single diagnostic test we can do to say someone has endometriosis or not. Yes, by doing examination, ultrasound scan. We have now a number of non-invasive tests by which we can reasonably say that one has endometriosis or not, but there is no single diagnostic test. A lot of work is going on and wait for the time when we do have one. And once we diagnose someone with endometriosis, there is no cure. We have no medication, pill, vaccine, something to give, say, oh, we give it this one, it will stop the disease to progress, or this thing won't happen. So there's no cure. And the quality issue rise right from quality of life all the way to fertility, which is obviously a difficult journey for many of you when you start from very young age all the way through the fertility and going forward having families. And the disease itself doesn't limit itself to one organ that is in the uterus and is in the ovaries. It's rather a multi-organ disease, which makes it even more challenging, going right from the uterus into fallopian tube, ovaries, and then going to rectum, bladder, going as far as to thoracic, endometriosis, and other structures. So that makes it very challenging, and hence making it even more important to have a multidisciplinary approach. We're talking about fertility here. So where endometriosis grows into all these structures, fertility becomes a very critical and very important issue. And lastly, that these all physical challenges then lead to even depression and anxiety going forward. Again, we can take it, next slide, please. And there could be a big chemical thing. Why it happens, this question comes. Obviously, this is not a forum to talk about that one, but there are immunological factors, genetic factors. A lot of work is going on a microbiome, how our guts are changing because of the foods and diets we eat. There are so many things goes on which creates a massive inflammatory chain reaction in the pelvis, leading to a number of issues from scarring, adhesions, pelvic issues, and obviously fertility, which is our topic today. Next slide, please. And then again, if we look at the issues now, a number of theories have been said about it, but again, we're just going to fly over it actually. Is it a retrograde menstruation? Is it a circular dissemination by the blood vessel? Is it an invasion, means cells are just progressing and from one cell to the other cell, making the disease progress? Is it an epigenetic or genomic alterations which are causing the problem? But there's so many theories from inflammation, angiogenesis. Again, we'll leave it on the side today, but there are so many ways to look at the endometriosis and why it grows and why it causes the problems which we suffer. Next slide, please. And that's where the issues come. That this issue of fertility goes all the way from uterus, ovaries to fallopian tube and to the whole environment which is built around the ovaries, which I'm sure Kate will come to us as well. But if we start the issue of the tubal factor, then tubes can be hydrocele injured, they are swollen, they can be blocked, they could be occluded, they can be damaged, and they could be luminal narrowing, there could be anatomical defects. The functionality of cilia which push the sperm on outside, they may not be functioning. It could be a range of problems in the fallopian tubes due to the inflammation of endometriosis, which can lead to these problems. Next, please. And if we look at any ovarian structure, any normal ovary will look like, where we have follicles, which are in tens of thousands, primary follicles leading to secondary follicles, tertiary follicles, and ovulating every month. But then when this very critical structure, this ecosystem within the ovary, which controls the fertility in detail, is then replaced with endometriosis, that's where the problem comes from. That all these eggs and follicles we see, they are now pushed to the periphery of the ovary, and the whole inner place of the inner core of the ovary is then covered with endometriotic chocolate fluid. And it's not only fluid, it's full of inflammatory cells, which then again change the ecosystem within the ovary, having a serious impact on fertility, which again, Kate will take us through. Endometriomas is again a bigger problem. So one is endometriosis leading to tubal damage, leading to create a cyst environment around the uterus, causing a problem with fertility. But then once endometriosis starts to happen within the ovaries, that brings even a bigger challenge for us. It's quite common. It occupies the whole space within the ovary. It can lead to oxidative stress, causing damage to the follicles. The blood flow toward the follicle can be impacted, having a negative impact. Follicular maturation get affected. Follicular atresia. There are a number of things which can start to get difficult and having an impact. Next, please. So all these things then again leading in different ways to have an impact on fertility as a whole. But I think we're going to break it up in small pieces. The question can come, is there anything we can do as surgeon where we can say, this is the level of your endometriosis and that's what your fertility will look like? Different things have been published and have been suggested. Endometriosis fertility index is one thing which has been suggested, in which we take the surgical finding of endometriosis along with their historic data, and then we combine them together in a mathematical way to come up with EFI score, which can be plotted against that patient to say that what's their chances of getting pregnant. That's EFI is used quite commonly in many fertility and endometriosis unit, and possibly should be used more. But again, there are questions how effective it is. Does it give us the right answer? And again, we don't have the one answer for that one. So again, I think I will move the discussion to Kate now to talk about, next slide, please. Yeah, that next slide, please. So that's the endometriosis fertility index that I was talking about, that what this something is used actually in many clinics in fertility and endometriosis to look at the fertility scoring. But again, the jury's out. We still have few things within this EFI as well, which are not very accurate. It doesn't give us the best number, but again, something to work with in this stage as well. Now, I think I will move the discussion to Kate now to talk something about fertility, and then we'll come back to your questions and giving answers to some very complex and difficult issues. Yes, Kate, please.
Great, thanks for the introduction, Amer. Next slide, please, Alice. Great. So I'm not going to don't want to cover too much of the same ground that Amer has just covered, but just to say that I think when I first started out in this field, we sort of just thought that endometriosis affected the tubes and that's how it caused infertility. But we've really moved on from that, and we really see now that endometriosis is essentially an inflammatory condition. And so, unfortunately, that really ends up creating this environment that's not particularly healthy for eggs and sperm and embryos. So, as Amer said, unfortunately, endometriosis can affect really the whole spectrum of fertility. So, unfortunately, it affects egg number and egg quality. It also affects fertilization and the chances of embryos implanting. And it can even affect sperm motility as well, this abnormal environment. And I think one thing that's often really overlooked when it comes to fertility is that, of course, endometriosis, one of the really common symptoms is having pain on sex, and that can be really severe, something that I think isn't really talked about very much. And of course, if sex is really uncomfortable, that affects everything, your libido. And so, of course, that influences the chances of conceiving as well. But having said all that, I think the really important message to stress is that actually around 60 to 70% of women with endometriosis go on and conceive naturally and have healthy pregnancies after a diagnosis of this. So I really don't want people to go away feeling that they will definitely end up needing fertility treatment. I think the default option in many cases is that it's perfectly reasonable to try naturally for some time. But I think what I want to get across today is that there are multiple options and talk about how we can individualize that to your case. So if we could go to the next slide, please. So what can I do? I think really important to say that I think if you've been diagnosed with endometriosis or have symptoms that are suggestive of endometriosis, it's really important to seek help early and get that diagnosis and get a fertility opinion. So we would expect to see women with endometriosis in the fertility clinic if they've been trying to conceive for just 6 months or more. So there's no need to be waiting. Like sometimes the message that comes perhaps from GPs and so on is that you need to be trying for a year or 2 years before we can refer you. Absolutely not. 6 months, and we were very happy to accept the referral. And particularly if people have known severe, deep endometriosis, then we will often even see you earlier than that. Because I think what's really important is to have a full fertility workup relatively early so that we can identify sort of all the various factors that might be contributing to the delay in conceiving. So, for instance, really important is looking at your ovarian reserve, the egg number. Typically, we do this with a blood test for something called AMH, anti-Müllerian hormone. But we also want to do an assessment of the tubes. Look at the uterus, and don't forget about the sperm as well. We want to check whether there could be any other contributing factors. And then based on all this information, we can work out what your options are and what the best way forward is. Obviously, anyone who's trying to get pregnant or is planning a pregnancy in the near future, really important to be optimizing your egg and sperm health. So I know it sounds really basic, but just to reiterate, not smoking, really optimizing your weight, having a healthy diet, plenty of fresh fruit and vegetables that are rich in these antioxidants that are really good to counteract the effects of endometriosis, and making sure you're on the right supplements. So folic acid, vitamin D, omega-3 has been shown to improve pregnancy rates. And as well, again, of course, it's not just the female partner for people in a heterosexual relationship. Of course, the male partner should be doing these things too. And then for most patients, it really comes down to a decision between trying naturally, treating the endometriosis, usually with surgery, preserving fertility, or going straight for fertility treatments. So we're going to talk through those options now. Just to say, in terms of the treatment of endometriosis, I'm going to focus more on the surgical side because, unfortunately, I'm sure as most people know, the medical treatments for endometriosis are typically hormonal in the majority. And so, unfortunately, these aren't generally appropriate when you're trying to conceive. Of course, they can be a really effective way of managing the symptoms when you're not trying to conceive. But happy to sort of delve into that side of it. Amer, perhaps more a bit in the Q&A as well, if we want to talk about the medical management. So moving on to the surgical side, just take the next slide. So the question of who might benefit from surgery has been really extensively reviewed. We've got these really good guidelines from the European Society that just came out a couple of years ago. And I've popped the link at the bottom. There's the website link to the patient version of this, which is really useful. And I'm just going to try and summarize this really simply. And again, we can delve more into this in the Q&A. But these guidelines have really shown us that for patients with superficial endometriosis, we know that surgical, so laparoscopic treatment of the endometriosis does increase the chances of conceiving naturally. So that can be a really valuable tool. For people with deep endometriosis, unfortunately, the fertility benefits of surgery are less clear. Quite conflicting data, not much pregnancy outcome data to interpret. And so the decision on whether to operate from a fertility perspective really comes down to symptoms and a lot of other factors, definitely more complex decision. I'm often asked about whether patients should have surgical treatment of their endometriosis prior to doing IVF. Is it going to make a difference? And unfortunately, there isn't really any convincing data that surgery, either for superficial or deep endometriosis, improves IVF outcomes. So we don't routinely recommend it. However, of course, there are special circumstances when surgery might be recommended before fertility treatment. So as Amer mentioned, when there's large endometriomas, or if one or both of the fallopian tubes are blocked and swollen up, hydrosalpinges, as we heard. But I think these are often quite complex decisions. And we just go to the next slide, please. I just wanted to try and explain why endometriomas are quite a problem for us from a fertility perspective. So during IVF, we usually need to do a transvaginal egg collection procedure. So on the left here, you can see this is a normal ovary that's been stimulated with medications for IVF. So there's lots of large follicles in it that are ready to do an egg collection procedure on. And what we do is we put a vaginal ultrasound probe in, and then, sorry, I can't use my cursor, but you can see the long straight needle coming in from the top of the picture into the follicle, hopefully. And so that's normally quite a straightforward procedure. We suck out that fluid, and then hopefully there's an egg in that fluid. On the right, you can see an ovary that has two just really quite small endometriomas in it. And suddenly this can make an egg collection much more difficult because we have only a very small passage to try and get the needle through. We don't want to puncture an endometrioma because that can result in infection. So it can affect the number of eggs we might collect. Endometriosis can also, they're associated with a reduced response from the ovary. So typically we don't get so many follicles as in a normal ovary. And then sometimes in patients with endometriosis, because of these adhesions, this scar tissue in the pelvis, the ovaries can be located not in their usual place, so they can be stuck higher up in the pelvis, and that can make it really hard to safely do an egg collection on. So definitely having endometriomas gives us a little bit of a challenge from an IVF point of view, but then why wouldn't you just remove them all with surgery before the IVF? Well, unfortunately, it's just not quite that straightforward. Just next slide, please. So this next slide's quite busy, but it's just really to highlight that because deciding whether to do surgery on an endometrioma can be really, really complex decisions because there's multiple pros and cons of surgery. The biggest one is that removing endometriomas, in some cases, depending on the surgical technique, can be associated with a reduction in ovarian reserve. So that then can obviously affect fertility. So I think it's really important that decisions for surgery are taken, not taken lightly. And we need to take into account many other patient factors like your ovarian reserve markers, how big the endometriomas are. Have you had surgery before for endometriomas? And what are your other fertility factors? What's your age? And really, I think this is why a lot of these decisions require an MDT approach. And, that's why I work with fantastic colleagues like Mr. Raza, so that we can have a really joint approach on this and really try and maximize the outcomes from the patient. So just moving on to the fertility options then, really it comes down to most people hopefully will be able to be in a position to at least try naturally for some time. But of course, a significant number of people with endometriosis will go on and need some form of assisted conception. And there's really two main options. Again, I'm just touching on these fairly lightly, so really happy to take much more in-depth questions on these. But the two main options are IUI, intrauterine insemination, or IVF, and this is either with your own eggs or with donor eggs if you have very low ovarian reserve already. Just briefly, IUI is where we typically give medications to boost ovulation. We then track this, and at the right time in the month, we take the sperm sample and inject it into the womb. So it's really just like nature with a bit of a boost. So really, this is only appropriate for women with pretty mild endometriosis and no other fertility factors identified. So the mainstay of fertility treatment would be IVF treatment. Obviously, this is the most medicalized of approaches, but does have the highest chance of success. And this will really largely depend on things like your age and the egg reserve. But that would be the most commonly recommended option. So next slide, please. And then just sort of finally on the presentation side, I think probably the most common thing I'm being asked now, I think, is about whether someone should consider fertility preservation, because of course many people who have been diagnosed with endometriosis aren't currently trying to conceive. I think there's been a huge awareness about the option of fertility preservation in recent years. I think there's a really strong case, for patients diagnosed with endometriosis to consider fertility preservation. And I think this is particularly true for people who are undergoing surgery for endometriomas. And just very briefly, again, to touch on, there's actually three methods of fertility preservation. I think people typically think of egg freezing. We do also have now, in some cases, access to ovarian tissue cryopreservation. It's still reasonably experimental. It's where we actually freeze a little bit of ovarian tissue, and it's mainly still just being done for patients who need urgent cancer treatment. There's been now about, I think, just over 200 births globally from ovarian tissue cryopreservation. So it's still relatively experimental, but I do think that this might be a really good future option. In endometriosis, you're having your laparoscopy, have a little bit of ovarian tissue, frozen, so you don't have to go through the IVF process to freeze your eggs. And then there's egg freezing, which I'm sure most people have heard of, and also embryo freezing. So for people in a stable relationship or who want to use donor sperm. Obviously, if you freeze embryos, it takes away the flexibility of the sperm side of things. So most people that I see are doing the option of egg freezing. Really important just to say that the success rates for egg freezing are so dependent on age, and really it's recommended ideally to do it before the age of 35. It's also really important to understand what your chances of success are before doing it. So typically, the AMH, the ovarian reserve markers, will give us an indication of how many eggs you might get frozen per round of IVF, per round of egg freezing. Because ideally, if you're under 35, you really need about 15 to 20 eggs frozen to give you an 80 or 90% chance of a live birth at a later date. So it's probably not as effective as many people think. You do need quite a lot of eggs frozen, and it's often that may require multiple cycles of egg freezing. So there's a lot to talk about, and when it comes to egg freezing, it's really important to have it individualized again to your circumstances and age and ovarian reserve markers. It's the other side of things with egg freezing is that we haven't got very much data from women with endometriosis who have subsequently used those frozen eggs. So the success rates are very much being generalized across all populations, just divided up by age. So I think I'm still very much waiting to see the success rates for women with endometriosis, because we don't quite know whether they will be the same as people without endometriosis. Thanks. Just my final slide, just very quickly. I did so I think just from the presentation side of things, really my take-home message is that majority of patients will successfully have a baby either naturally or through assisted conception. But do please seek help early and speak to a fertility specialist who can look at your case individually. But also just really important to be managed in a place that does have access to this multidisciplinary team. Not just fertility, brilliant surgeons, colorectal teams, but I think also just really important to have the emotional and psychological support that's so needed during these difficult journeys. And I think hopefully we're going to hear a lot more about that side of things from Carla later on, which I look forward to.
Great, thank you very much, Kate. Very helpful, and you just finished it very nicely on time as well. Is Carla with us now? Okay, that's wonderful. Hi, Carla. Are you there? Can you hear me? Carla, can you switch on your mic? Maybe mic is off. I can't hear you.
Hello, can you hear me?
I can hear you, Carla.
Oh, amazing. I'm so sorry. We had a real drama trying to get me in.
No problem. Thank you very much for coming in. So look, Carla is a very well-known name. She's founder and CEO of the Endometriosis Foundation. She's done a huge amount of work. Carla, I want to ask you a question before we go on to a lot of questions now. What is your personal experience has been with suffering yourself with severe endometriosis, your fertility journey? Can you take us briefly through it, and then we'll go next?
Yeah, and Kate, that was a really helpful and interesting presentation. Amer, I'm so sorry I missed yours, so I couldn't get on. But I mean, for me, I'm coming in from the other side. I received my infertility diagnosis when I was 20, just turning 25, and at the time I received my endometriosis diagnosis as well. So I'm kind of coming from the other side, but I think for me, when it comes to kind of fertility, it's quite an anxiety-provoking subject for me, because my fertility is still quite unknown and unsure. And I think I did manage to freeze my eggs, but not very many. And I had a very low AMH, and it wasn't great. But I mean, I was diagnosed, like most people, really late. I was under my GP from the moment my period started, and I actually saw a gynae when I was just 14 with majority of the symptoms of endometriosis, but nothing was seen, and I was kind of sent on my way and trialed on various different hormone treatments to try and regulate periods and limit them as well, because they were just so painful and irregular. But as time went on, it was obvious something was wrong, and I think that's where my frustration comes from when it comes to kind of my journey and so many others whose kind of journeys are similar to mine, is that I knew for so long that something was wrong, and I was consistent with trying to seek help and trying to find answers. But I was just kind of hitting a brick wall when, being told that, it's something you'll grow out of, or, we'll carry out a scan, but nothing's seen, and it can't be anything serious. But then eventually when I finally got diagnosed, it was too late. So I think there's a lot that's not really spoken about in terms of kind of the emotional side to endometriosis and fertility. And now kind of from the charity perspective, seeing other people going through it and the anxiety that brings. with the uncertainty. And of course, not everybody will have these problems, but unfortunately, there are some of us who do. And I think, yeah, it's important that we kind of raise awareness of that as well. But yeah, I think for me, it was quite a turbulent time, and I had all these diagnoses at once. But Amer, and this is why I love this event, and I love all that you guys do, because there's just nothing like this when I was diagnosed, and I would have learned so much. And I wish for me I preserved my fertility a lot earlier, a lot sooner, but I wasn't aware of the implications to infertility, and I wasn't even aware of endometriosis. So I'm hoping, obviously now things are changing, there's more awareness, so hopefully people won't be going through these kind of horrific journeys with a lot of kind of negligence, really. And yeah, events like this can be so helpful.
Thank you very much, Carla. That's a very good background on how we all suffer with the diagnosis and then getting the services for fertility. Now, Kate, coming back to you now, let's start from here. Egg freezing. It's a very common now. Everybody's talking about it. We have a lot more referral for egg freezing in the recent times. And let's open it up a bit now. If someone has mild endometriosis, are there any, and they are concerned about their fertility, are there any tests would you like to do to check their fertility? And what will be your advice about egg freezing in that population?
Yeah, absolutely. I mean, I think that the first step is that we're always trying to weigh up with egg freezing. What are your chances of actually needing to use these eggs in the future? It's sort of weird. You do spend probably a lot of money, go through quite a big process, and actually we're hoping that you never need to use those eggs in the future. So it's always a challenging one. And in someone who's got quite mild endometriosis, you'd really hope that they'd be able to conceive naturally and never need to use frozen eggs. Having said that, anyone that I was seeing, I would definitely do a bit of a fertility workup. And I think probably the most useful test is an assessment of ovarian reserve. So we would usually do AMH, so that's the blood test for anti-Mullerian hormone that I mentioned. The other way of looking at it is antral follicle count. So that's an ultrasound-based test where we look at the number of small follicles, developing follicles on the ovary. But we know that particularly in people with endometriomas, antral follicle count isn't as sensitive. So AMH is probably the best biomarker we have for egg reserve. And I think really, I mean, Carla's just said it, you know, the problem with egg freezing is that in people with low ovarian reserve, you often don't get many eggs collected. So we really want to be trying to do fertility preservation before someone's egg reserve drops. So I think anyone who's at high risk of fertility issues or low ovarian reserve, I think should be considering egg freezing. So I think in mild endometriosis, if you really have very, very mild disease, normal tubes, normal AMH, I would probably be inclined to at least monitor the AMH. But certainly, you know, sometimes we do offer egg freezing in that situation if people are, you know, are worried about their future fertility. But I think the benefits of it are probably slightly less clear when it is quite a mild disease.
And sticking with the same concept of mild endometriosis, and you please tell me otherwise, that if we do the excision of endometriosis in mild cases, it improves the natural conception rate. However, we shouldn't be operating on someone for the fertility reason. The operation should be on the basis of symptoms of pelvic pain, period pains, and that should be the primary reason for us to do laparoscopy.
Yeah, absolutely. I think we've really moved away now, haven't we, from the sort of routine laparoscopies in fertility patients. So I think very much it has to be guided by patient symptoms, because at the end of the day, surgery has its risks. So it's not something that we want to undertake lightly. But certainly for people who are young with good egg reserve, who you know want to ideally conceive naturally, some treatment of mild endometriosis, we know that will improve natural conception rates. So really worth doing.
And other thing which came out very strongly in your presentation as well, and I want to just repeat that one of the most challenging things we have in endometriosis treatment surgery is endometriomas. That's the one which is directly linked to your fertility. If peritoneal endometriosis, rectovaginal disease endometriosis possibly will not impact on fertility as much as if we are doing endometrioma excisions. And these decisions has to be taken in the context of lengthy, difficult, but right discussions in the MDT with the patient with all the information. And we have learned over time that if we do cystectomies, which means we remove the cyst or the endometrioma from the ovary, it leads to damage to the ovarian enteral follicles and the AMH level as well, and AMH level come down. A number of things have been done. For example, people talk about, should we do just laser diathermy to these endometriomas? Should we just drain them and leave them? Alcohol sclerotherapy is a new thing now, and we think that possibly data is better, but still jury's out and more research needs to be done. But surgery on endometrioma means when it's in the ovaries is a challenging thing, and a lot of discussion needs to happen between yourself if you have endometrioma and with your surgeons, that what will they be doing with the ovaries with these endometriomas. The challenge for surgeons is if we just aspirate the endometrioma and do not remove the cyst, then it means that recurrence rate will be high. So this risk of recurrence should be balanced with the risk of the eggs and follicles if we do cystectomy. Obviously, the way out could be that before we operate, patient goes to the fertility and gets egg preservation, and then eggs are frozen. Now they come back and they can have more definitive treatment, so this recurrence is reduced. But these are those kind of discussions which everyone needs to have with the surgeons, that how they will be managing the endometriomas and the ovarian cyst. Let me come to a few questions as well, Kate. I will ask this question and we'll go through these questions quickly. And I should tell all participants, thank you very much for so many of you join us, that if we are not able to answer everything, we will, our denial specialist nurse will be able to email you these answers, and these answers will be available on our website page as well. So let me get this question to you. I was first diagnosed with polycystic ovarian syndrome, then endometriosis. Are these two conditions linked? And am I correct in thinking that PCOS will further impact my fertility? Kate?
So PCOS is essentially a metabolic condition. So it's quite different to endometriosis. So typically you've got multiple ovarian follicles, and this is associated with hormonal imbalance, so abnormalities in your insulin and testosterone levels. It definitely affects fertility, PCOS, because primarily because it can cause dysovulation, so you don't have regular ovulation, so it can make it difficult to conceive, and it probably can affect egg quality as well. And the only sort of benefit of having PCOS is that you do have lots of eggs in the ovaries. So, you know, for people doing egg freezing, typically get a lot of eggs collected, which can be good. But unfortunately, the sort of PCOS and endometriosis can coexist, but they are quite distinct pathologies that require slightly different management.
Right. And there's another interesting question here. Is there any correlation between stage of endometriosis and likelihood of fertility issues?
Endometriosis is one of those really frustrating conditions, isn't it? Because we know that you can have really severe symptoms, but at surgery, the endometriosis is classified as, you know, maybe stage 1 or 2, and you can have the completely reverse. You can have almost no symptoms and have really severe, deep endometriosis. From a fertility perspective, Amer mentioned about the endometriosis function index. So after the endometriosis fertility index, so after surgery, we do know that the surgical findings, when combined with some factors like age and your previous pregnancy history, it does correlate to some extent with conception rates. Whether that's whether through trying naturally or with IUI. So there is useful information that can be, so basically the more severe the endometriosis, unfortunately, the lower the pregnancy rates, to make it very, very simple. But of course, you know, you've got to consider all the other factors as well. But generally speaking, for most people after you've had surgery, what we see with the fertility index is that all patients have some chance of natural conception, but at around about 18 months, really these graphs, Amer showed us it very briefly, the levels of conception rates really sort of start to tail off. So I think for most patients, it's reasonable to try some duration of natural conception, depending on your AMH and whether the tubes are patent or not. But even in people with the most mildest disease, after 18 months, we know that probably the chance of conceiving naturally are reasonably small. So at that point, it's reasonable to move to assisted conception.
And we can also add that if it's a mild disease, then the likelihood of your fertility is much better, as Kate already told, that most women, 80% of them will go on to conceive without need for anything if it's a mild one. We have seen that in severely deep infiltrating endometriosis, if it's involving the bowel, then the success rate is about 20%. And if there is no bowel involvement, about 40%. So there are some numbers, yes. So severity of the disease can have relation with the fertility. Okay, there's another question here. Could treatments for endometriosis like taking Dynogest or having Excision affect my fertility? Kate.
So obviously when you're trying to conceive, as I mentioned, treatments like Dynogest are hormonal. Essentially, they suppress your hormones, stop your periods. That's why they're very effective for treating endometriosis often. But obviously you can't try and conceive when you're on these treatments. However, I think there definitely is a role for them from helping reduce progression of endometriosis. So if you're not in a position to be trying to get pregnant, being on the medical treatments will hopefully at least keep the endometriosis as quiescent as possible. But unfortunately, there's no role for prescribing the medical treatments to improve fertility. So taking Dynogest from 6 months isn't going to help your pregnancy chances, unfortunately. So just not something that's recommended.
I'll go to a little bit political question. I'll come back to some more questions as well. Carla, are you there with me?
I'm here.
So Carla, you have worked quite a lot with all parliamentary group as well in the parliament to see how we can improve the standard of endometriosis, especially in fertility, such a challenging area with very limited resources in the NHS. Can you just give us a little bit background and what the outcome has been after all that work?
Yeah, sorry, I put my camera on, but it just switched back off. Got a funny
yes, come on now. Yep.
So for me, something that I'm really passionate about is to kind of advocate so that everybody gets the fair treatment. And at the moment, it's really hard to access, and a lot of it can just fall down to where you live, your postcode. And that's really not fair. There's lots of different groups and charities and amazing people campaigning to change this so that access to care is, fair and equal. And there's a lot of work to do and a lot to go. But we actually earlier this year, and I know we took one of your colleagues, Tom, along with us, took our fertility campaign to Parliament. And the goal for this was to really get people talking about the connection, because you don't really see or hear much about endometriosis and fertility and linked to infertility. And so for me, having that taken away from me, and for myself, my own personal experiences and so many others as well, that was really important to me as our kind of first campaign through the charity. So we had a really kind of big day in Parliament, but then obviously there was an election and everything else, but the APPG has just been re-established. And there's some kind of things going on in the works. These things take a long time as well, so it's just about getting the right support. But there are a lot of things kind of happening. We're actually there next week for a meeting with the chairs of the APPG to really push this campaign, because anybody in a position, I believe, where maybe they're having an operation to remove their ovaries, or like me, their ovaries and their fallopian tubes, to be kind of denied that treatment, especially when they may have faced years of kind of battling with GPs to actually get kind of a diagnosis. They deserve more and they deserve to be treated better. So that's kind of what we're pushing for at the moment, kind of equal and fair access to fertility support and care. And we ran a survey in January of this year. This is again what we took to House of Parliament, and I think it was over 70% of people were concerned for their future fertility. And I mean, it can be even really difficult just to request an AMH test. A lot of people are denied these kind of basic hormonal tests. I know I was for years, and still now it happens. And we're often kind of trying to find private companies that are offering these tests fairly cheap and recommending them, because it can be a real battle to get past the GP to get them, or even to get a referral to fertility. So again, the access to care can be really challenging, especially depending on where you live. So it's just really a focus for us is to really kind of shimmy these obstacles out of the way and create these kind of more pathways, and hopefully encourage for some funding to be put into that area. But certainly starts with education. I mean, if I had known even what endometriosis was years ago, when I was going through all of that, years and years of being hospitalized for my periods and not knowing why, my life could have been so different. So yeah, I think obviously early intervention, early detection is key, isn't it?
So I think I would just say this comment that Carla, you yourself, Endometriosis Foundation, Endometriosis UK, Mental Health Project, and all the other charities are working. You're doing a fantastic one. And while the new government takes its place, make sure they get their priorities right, keeping endometriosis on top of that agenda as well. So keep working hard. Okay, very good question. Next one is, I have an 8-centimeter endometrioma. IVF has been stopped because of the risk of ovarian torsion. Can I continue with this risk? I will ask you in a second. It's just a question. But whoever asked, there should be no ovarian torsion in 8-centimeter endometrioma. It's very uncommon. Endometriomas are actually stuck with the pelvic sidewall. They don't tort. So there is some possibly misunderstanding somewhere. There may be some other reason. But Kate, do you want to comment on this as well?
Yeah, I completely agree. Incredibly rare for endometriomas to tort. I mean, it may well be that they feel that access is an issue. As I mentioned, maybe they will not be able to access that ovary. Maybe they are concerned it will significantly affect the ovarian response on that side. I think this is a case that exactly my management of this would be immediately to have a discussion with Amer. Look, is there something more conservative we can do on this ovary to maybe, as a temporary measure, manage that cyst? Then I could do IVF, stimulate, collect the eggs, and then potentially need more completion surgery after the fertility treatment. And I think that's been our approach quite a lot over recent years, hasn't it? Trying a more conservative approach initially to really minimize that damage to the ovary and minimize the impact on ovarian reserve.
And the question will you, Kate, will be, I think the right approach has to be for large endometriomas to have the egg freezing done. They come in, they have a proper definitive treatment, because 8-centimeter endometrioma, if I'm just aspirating the cyst, it's going to come back. It's a matter of 6 months, it will develop again. Now, the question to you will be, if I send you 8-centimeter endometrioma, how easy or difficult is it for you to stimulate that ovary and to be able to collect the eggs from that ovary, which may well not be very, very easy?
In all honesty, I'm going to be more focused on what the other ovary looks like, because actually, if you've got a really good egg reserve or a reasonable egg reserve, maybe we do get enough eggs from the other side. I think at 8 centimeters, I would be very wary about putting needles into that to collect it. But look, at the end of the day, you see how the body responds. Sometimes we get lucky and actually the follicles come up before the endometrioma, so we can collect some eggs from that side. So you would always try on both sides, but an 8-centimeter endometrioma unfortunately is going to significantly affect that side and the ability to collect eggs from it.
So can endometriosis cause miscarriage?
Yeah, it's a really good question, and the data is a little bit controversial. It's not particularly high quality, but unfortunately, they have shown slightly higher rates of miscarriage and ectopic pregnancy in patients with endometriosis. Most pregnancies are healthy, straightforward, particularly in later pregnancy. But this is probably related to an egg quality or implantation issue. So there are very slightly higher rates of miscarriage seen, unfortunately.
Thank you. Does deep infiltrating endometriosis affect the birth options? I can just give you an answer. No, it should not affect the birth options. Mostly people will have their birth option normal delivery, section, depending on how their pregnancy goes. It should be fine. Next question is, I was first diagnosed with PCOS, and I think we've done this question. I'm booked for laparoscopy in December, being told excision of endometriosis could improve fertility, but is there any risk complication of laparoscopy making fertility worse? Now, your question does not tell us if you have endometrioma or not. If your ovaries are spared of endometriosis and it's only peritoneal endometriosis, and the surgeons are planning to do excision of peritoneal endometriosis, then I don't think it should have any impact on fertility. Kate, any comment, please? You can disagree with me.
Completely agree, and it might even improve it. Maybe free up the tubes a bit, improve things. But, yeah, I agree. The key thing is, if there's endometriomas, we just worry about the effect on ovarian reserve. But otherwise, for peritoneal endometriosis is potentially a good thing.
That's right. I have bilateral endometriomas 4 centimeter taking Dynagest, which is very common now. Many hospitals are using Dynagest, which is a progesterone only 2 milligram tablet actually. I'm 32, never tried for pregnancy. In your experience after excisional endometriomas, Does this improve fertility? Okay, I think you've got the answer already, what we have talked so far. So she has bilateral endometriomas, 4 centimeter, taking damage, 32-year-old, never tried for pregnancy, and asking if excision of endometriomas will improve fertility. Kate?
Yeah. So if you've got bilateral endometriomas, we know that removing those puts you at higher risk of low ovarian reserve. So if you just have a single endometrioma removed, your AMH might drop by about 40%. If you've got bilateral endometriomas, it might drop by 60%. So, and we know from the data that actually just treating the endometriomas probably isn't going to improve your pregnancy rates. So again, we would only really be recommending removal based on your symptoms if it was needed from symptom management, so not necessarily from a just pure fertility point of view.
Can I have my eggs frozen on the NHS prior to excisional surgery?
Well, just going back to what Carla's been saying, it's this awful postcode lottery situation. At Chelsea, I can tell you what my experience at Chelsea and Westminster is in that our funding bodies near us, if we think that someone is at pretty significant risk of infertility because of their surgery, i.e. they have significant endometriomas, we can do egg freezing on the NHS, but it's on a case-by-case basis, and there's lots of hoops to jump through. We need to apply for funding and you need to fulfill certain criteria. It is worth asking that question of your local areas. Carla.
Yeah, and I just wanted to mention, because quite often when you apply, quite often automatically refused, and not many people know that. So it's the really important part is the appeal, because then you get to write to them and explain your situation as well, and your medical team can also write to them too, because that's what we had to do for mine. So the application process is really not straightforward, and it's quite disarming as well, because you'll get an instant no after applying, but actually when you appeal that, and we appealed mine 3 times and finally got it, so it wasn't easy, and I was due to have both ovaries removed as well. Sorry, I just wanted to jump in
there. Is egg, okay, we've done the egg freezing question. It's really lottery. Can you pay privately for fertility testing? Yes, you can pay privately. There's so many clinics. You can just Google yourself wherever you live, and that can be checked. And we already said, Kate told us that if you want to do fertility testing, one of the most sensitive tests we have to date is AMH, which you can do. Obviously, ultrasound scan with the entry follicle count can be done, but AMH is more agreeable test. How reliable is a 21-day ovulation blood test? I will just go on from there because we want to talk about endometriosis. How soon after excisional surgery, stage 4, should I start trying to get pregnant? Kate, what do you think?
I would say as soon as possible, please.
Yeah, that's right.
What do you say, Amer?
Golden time. I will say any surgery you have, either it's a mild to moderate endometriosis or severe endometriosis, once you have the surgery done and you're recovered in next 2 to 4 weeks or 6 weeks, you get your first period, you're absolutely right to go and try to conceive. There's no point of waiting after that one. Next question. Should I stop taking desogestrel before my excisional surgery, planning to start trying to get pregnant afterwards? Before my, no, you don't need to stop desogestrel before, but if you want to start trying to get pregnant, yes, absolutely. We already said to you that you are in the golden 6 months after the laparoscopy. So yes, do stop desogestrel, have your surgery, recover from the operation 2 to 4 weeks, next cycle, and you can try to conceive again. Is there any link between hypothyroidism and endometriosis? My only comment will be these diseases could be very autoimmune, and we know immune factors are also implicated in the causation of endometriosis, and number of reasons for hypothyroidism are autoimmune. So there could be some link between them as well. Okay, how many minutes we are left? We're left with 2 minutes. So just to say before I go to the next question, thank you very much for everyone to join us from Cromwell Hospital. Thank you for their organization as well. They're helping us to set up the webinars. Last one, we talked about multidisciplinary meetings. We talked today about the fertility issues. And our next topic is going to be about severe bowel disease and endometriosis. We'll talk about stomach care, and we're also looking at how we can do webinars about psychological health, dietary health, and physiotherapy. So we'll bring all these topics in the next coming webinars. So please sign up for our letter, and we will keep going this discussion among us. Next question is IVF a solution if you have difficulty in conceiving with endometriosis? Kate.
I mean, of all the fertility treatment options, IVF will have the highest chance of success. So that's probably the most common treatment that I recommend. Yeah.
I've been told by doctors that getting pregnant is a treatment for endometriosis, but also endometriosis can make getting pregnant difficult. I'm confused. Yeah, let's make it easier for you. So number one, getting pregnant is a treatment for endometriosis. We hear this thing very often. Even I say in a different way as well. It's not a treatment actually, but when you are pregnant, then the estrogen level goes down and you have no periods. And when we have no periods, it tends to help the symptoms. So the scarring and adhesions which is developed due to endometriosis may not go away. It still can stay, but obviously you have no period, your symptoms will get better. So symptomatically, it's absolutely good when you conceive and get pregnant. Now, endometriosis can make it difficult to get pregnant. Yes, in some people, yes, but 80% we said you will go on to conceive without any problem. But 6 months is a reasonable time for trying to conceive. If you're not pregnant in 6 months, then it's the right time for you to contact your fertility doctor. And again, if it's severe disease diagnosed bilateral endometrioma, then it's even good not to wait for 6 months and go ahead and consult a fertility specialist if you've tried for some time as well. Okay, one more question, possibly I can take it, and rest question will email you the answer. And that would be, any benefit to have fertility assessment before trying to conceive? I'm 33-year-old. I have a stage 4 endometriosis. I'm 18 months from post-excisional surgery, now on decapeptide injection, aiming to conceive next year. So with that difficult history of stage 4 endometriosis, your question is, any benefit to having fertility assessment before trying to conceive? Kate.
And so decapeptyl, obviously being a GnRH analog, is going to essentially put you into a sort of medical menopause. Going to be hard to interpret an AMH accurately on that as well. So I think you just have to be careful about doing fertility assessments when you're on hormonal treatment, because they might not be accurate. And in most cases, I would do a brief assessment, possibly nearer the time, but you may want to just try conceive naturally. But I would say if you haven't conceived within 6 months, then be seeking fertility assessment.
Absolutely. One more question I'll take is an important question. In a same-sex relationship, are you eligible for fertility testing before going through 6 months of trying to conceive?
Yeah, so you can be referred. Again, this is another terrible area for funding, and the Women's Health Strategy is hoping to change that, but we haven't heard the result of that yet. But yes, you can be referred to the fertility clinics for assessment, and in most ICBs at the funding body areas, if you have a significant fertility factor such that you need IVF, that should be NHS funded. Same-sex couples have to do a certain number, usually 6 intrauterine insemination cycles first if they've got no fertility issues. But if you need IVF, that can be in most areas NHS funded.
That's right. Look, there are many more questions we could come back to, but now it's time to finish this webinar. I'm so grateful for Kate McLaren for you to come and join us. You're absolutely amazing support for our all complex endometriosis patients. Thank you very much for supporting us privately, but also supporting the NHS very major hospital. And thank you very much, Carla, for taking time as well to coming and talking to us. You are absolutely a big voice in endometriosis. Please keep up the great work. And everybody who has joined us, I hope we have tried to answer some of your questions. But my last message will be, if you have endometriosis or someone you know have endometriosis, fertility is a very important question. When you go and see your doctor, ask the right question and try to get the right answer. Secondly, if you have endometriomas, then you need to really get this answer, how they're going to treat your endometrioma and what impact is it going to have on your fertility. And if you have a complex endometriosis, then make sure that department is working MDT with a fertility specialist and you're getting the answers for your difficult questions. Thank you very much. Thanks, everybody. And I will just say thank you to Cromwell Hospital for all the support and great work with Alice and all the team has done for us as well to do this webinar. Thank you very much.